Thank you, Dr. Harsh, for giving such practical points about the optic disc assessment. We'll now move to the next speaker, who's Dr. Shibal Bhartiya, who will speak about the philosophy of medical management of glaucoma.
Good evening, and sure, I'll just start my screen share, please. Good evening. It's such a pleasure to be here, and I've got three of my favorite teachers on the webinar listening in. Oh dear God, let this not go wrong. Just please give me a minute while I get this sorted. Yes. And it's going to be really ridiculous because am I on screen share?
Yes, you're on screen share.
Wonderful. So it's going to be a pleasure to be here, of course, and I'm going to be walking you through the relatively more abstract art of glaucoma practice, and all of the experts are going to be talking of the science and the very analog science of what we do for our glaucoma patients. And now, before we go on to that, I will be talking of the fuzzier, more cognitive realm of why we do what we do.
Could you just move to full screen, please? You're on.
I'm not on full screen. Just a second.
Put it in presentation mode, Doctor.
I thought I did. Is that better?
Yes, that's fine.
Yes, wonderful. Thank you so much. So underlying our glaucoma treatment philosophy, of course, is the best accepted definition of glaucoma. The disease is asymptomatic, it is chronic, it is usually progressing very slowly, and it is a painless optic neuropathy. But we often forget the other bits, the ones that are not in the definition, which actually should be guiding how we look at a glaucoma patient. The diagnosis of glaucoma is more often than not a surprise. Most of our patients are diagnosed when they are visiting for something entirely different. And glaucoma diagnosis, even today, remains scary. Kala-motia is a dreaded word in my part of the world and yours. And the fear of blindness is real and present in the minds of all of the stakeholders, whether it is the doctor, whether it is the patient or the patient's family. So what do we look at when we were to look at the cognitive aspect of glaucoma? What really happens when the diagnosis of glaucoma happens is that there is a sharp drop in the quality of life of the patient, basically because the patient has just been told he has a disease for which there is no cure and one that requires lifelong therapy. Thereafter, both the interventions, which are therapeutic or diagnostic, also affect the quality of life. And once treatment starts, there is a steeper decline in the quality of life than we presumed would happen. This is not just the vision-related quality of life, but also the other parts of the quality of life. The vision-related PQLI deteriorates faster than presumed, not just because of the visual field damage, but because of the visual disturbances related to the inevitable ocular surface disorders. Which is why when you look at the target IOP definition, it centers not on the IOP, not on the optic nerve, even though Dr. Harsh walked us through it so beautifully, not on the visual field, which is the final denominator of glaucomatous damage, but against the patient's quality of life. And the consensus there also is that the risks of therapy must be balanced against the risk of disease progression. So even though glaucoma is really not a number game, and if you were to look for least common denominators, because you need to measure what you're doing, we are really working on the metrics that really don't define the target IOP quite so much. We're looking more in terms of intraocular pressure, whether it is peak or fluctuation. We're looking at the visual field and what is happening to the RNFL and the optic nerve. But what we should also be looking at and collating are the quality of life costs of what we are doing, the dropout rates from our treatment paradigm, and the compliance and adherence rates. So today I'm going to see if we can, reach at some kind of a walkthrough to the paradigm of this particular treatment and see if this warpage can be in any way eliminated. So the first thing to remember is that drops will not work if the patients are not using them, regardless of what you choose. And almost any drug that you choose for your patient is going to have a very high early dropout ratio, irrespective of what you decide to do. And it is attributable to the fact that the initial scare that you have of blindness over time will decrease. Also, the patient will kind of get more desensitized to the whole idea of a disease which is chronic and progressive, because really for the longest, they're not going to have any symptoms that are commensurate with it. And your treatment is going to cause a lot of problems for the patient. So the bottom line then is that you start treating the patient and not the IOP. Common sense and all of the guidelines also recommend that we assess the patient as a whole and individualize the patient's the treatment plan to the patient's needs. So we are looking at providing IOP reduction, which is effective, but remember that effective IOP reduction requires the patients to cooperate with you. And two of the most important attributes to patients listening to you are safety and tolerability of the medication that you have chosen for your patient. So when we look at a more holistic approach, we are of course looking at something which really takes care of the intraocular pressure and is easy on the eye, gentle on the patient, but tough on the IOP. So what we are going to look at is whether the efficacy, when Shamira is going to walk you through this actually, efficacy in terms of IOP, both mean and reduction, as well as 24-hour control, leading to a stable visual field function. And when we look at the side effect profile, we're looking at both systemic and ocular tolerability, and consequently patient adherence to the particular treatment plan. In this also, what we often forget is this one person who's central to all of this, the patient, and her or his preferences in terms of what they want done to themselves. So when we're looking at the efficacy measures, we're going to go through these in detail, so I think I can just rush through them. We're looking at percentage IOP lowering in both treatment-naive patients as well as when we are switching treatments. We will look at diurnal fluctuation control because most of us who do DVs know that that is a bigger cause of glaucomatous damage than just the peak IOP. And when we look at consistent long-term efficacy, we realize that IOP is only a surrogate for visual field and function, and the ultimate aim of any glaucoma therapy is visual field stability. Now, before we move on, I would like you to come back to the first graph that we'd looked at. Glaucoma has no symptoms usually until you start treatment. So the more effective central idea of glaucoma treatment is compliance and adherence, tolerability and side effects, cost, both economic and to the quality of life, and ease of use of the drops that you've given. So what you have to understand that since the only modifiable risk factor for progression is IOP, all of our therapeutic efforts are directed towards reducing IOP. But the fact is that what we have to look at is the quality of life cost per millimeters of the IOP. Now, the thing is this a price your patient is happy to pay? And have you discussed it with your patient enough? Tired eyes, sore eyes. I have post-viral dry eye right now, so I know how difficult it is for me to look at the screen for longer than half an hour. And for somebody who has to deal with it lifelong because of what you have done to them is not the easiest. And a prescription of a lubricant, I think, is almost an everyday occurrence in any glaucoma clinic right now. And we forget, very importantly, how the dry eyes can impact the eventual clinical outcomes of glaucoma. So remember, more than half of our patients end up having some kind of ocular surface issues, and about 25% of our patients will drop out from glaucoma therapy because of ocular surface disease issues. And if your patients are anything like mine, they will continue to use their lubricants and forget to use their glaucoma medication because that doesn't make them feel very good. So it is important to remember that and recognize that the management of the ocular surface issues may just improve the clinical outcomes in terms of patient quality of life and eventually also the metrics which are objective metrics of glaucoma treatment. Which brings us to the other biggie that we often forget to talk of when we talk of glaucoma therapy, which is communication. We need to talk to our patients more about the disease, about their fears, about the treatment options that are available, about side effects, about their remedies, about other possibilities, and what it is that we can do to make the treatment less painful. The most important single conversation that you need to have is to teach your patients on how to use these eye drops, because that's the one thing that changes the way glaucoma is managed. If every time you see your glaucoma patient, you can take a minute and ask them to either demonstrate how to use their eye drops or do it yourself and show it to them, it's probably going to modify your glaucoma outcomes more than anything else. No amount of conversation can replace this particular demonstration. Now, it is also important to remember that glaucoma patients invariably struggle to put their eye drops, whether it is, even if they do remember to use them and when they remember to use them, most of them are elderly and arthritic fingers, and most of the eye drops, if you've tried putting them yourself, require practice. And as many as 50% are unable to put their drops without assistance, especially the elderly. And this does not depend whether you're using multi-dose or monodose vials, or the gender of the patient, or the duration of disease. This is also an important consideration when you go around asking your patients to put eye drops one after the other, which brings us to the all-important and the most often ignored metric of glaucoma practice: patient centricity and ethics. Now, what is best for the patient, what you think is best for the patient, and what is the best possible route in a given clinical situation. So all of medical ethics hinges on 4 particular points that we need to go through one after the other. The first, of course, is patient autonomy. A glaucoma patient must have the freedom and the agency to make an informed choice, which means you need to have enough time to educate the patient and empower the patient enough to share your decision making, and that there is a value-based customization of your treatment plan. Eventually, this is time well spent, because the patient then will adhere to the treatment better if they have shared in the decision making. They understand why they are part of it. Now, beneficence and non-maleficence are words which are not requiring any explanation. Of course, the patient has to be benefited by the therapy for us to choose it. And of course, the collateral damage must be minimal for us to choose a particular therapy. Justice, both equitable and distributive, this is something that has come into sharp focus during the pandemic, because as we are, like Dr. Harsh was also saying, we are stratifying the patients that we call to follow up. And well, that's a clear violation of this one ethical principle, because just because somebody has early glaucoma does not mean they do not require follow-up. But during a pandemic, this particular principle of patient centricity and ethics gets to be in that gray zone where you are supposed to take a call depending on the individual, which is where we are in terms of the ethics and patient centricity. At the end of the day, as in life itself, glaucoma treatment paradigm is all about making intelligent choices guided by education, knowledge, and gestalt. You just have the body of experience that tells you whether something is normal or not, that tells you whether something is working for the particular patient or not, and conversation is key to making these intelligent choices. The decisions that we take just not make us susceptible to COVID, but in this case, this is a decision which will actually make a difference for someone who is going to progress from where they are right now to darkness. And when we took our Hippocratic oath, for some of us not so long ago, and for the others much, much longer, all of us promised that first of all, we will do no harm. And it is important to remember that that continues to remain the guiding principle for glaucoma practice. Glaucoma has no symptoms. All of the glaucoma medication that you will choose will cause symptoms. Target IOP is not so much about eye pressures as it is about quality of life of the patient. Efficacy is extremely important. Tolerance is just as important as efficacy. And both the doctor and the patient have to be happy for a treatment to work. It is something that you have to remember each time when you strive out to think of what you need to do better for your patient. Balance is key. And at every point in time, the risk of therapy has to be more than the risk of progression for you to actually prescribe it. And in case I was given less time than I have been allotted today, or if I was as lazy as I am and did not want to make slides, this last slide would have been absolutely enough to sum up our conversation today. This is from Hutchison's Manual of Clinical Medicine, Clinical Methods. And I think this holds true for glaucoma more than anything else. Do not let the cure of the disease more worse than the disease itself. It is critical to remember that every time we offer the patient a choice where a drug is going to make the patient more miserable than they are at this point, we must have a very good reason to do that. If we will remember this, I think that particularly sums up all of the philosophy behind glaucoma therapy today. Thank you so much for your attention.
Thank you, Shibal.